current series from the Hand Education Committee from AO North America. As most of you know, over the last 2 years, we've been in the middle of a pandemic, and it has created a host of opportunities rather than problems, especially in terms of online learning. And the Hand Education Committee has grabbed this opportunity with both hands and cemented itself as the global leader in hand surgery education. We've been through numerous series and wonderful talks, nearly 75 webinars all told, but we did not do one thing, and that was covering complications. It's a bugbear for all of our practices, but one that needs to be discussed. So it's only fair that this last series during my tenure be dedicated to complications in upper limb surgery. Over the next 7 weeks, we have promised that you will have wonderful sessions where you'll learn a lot, and it should be humbling as well as exciting. So with that being said, I will turn it over to the moderator of the first session, Kim Mesra. Kim, all yours.
Thank you, Dr. Mudgal. So yes, I'm Dr. Kimberly Mesra from Dallas, and I'll be your moderator this evening. We have an esteemed panel this evening for our faculty, Dr. Amit Gupta from Louisville, Dr. Marco Rizzo from the Mayo Clinic in Rochester, Dr. Bridgman from the Missouri Orthopedic Institute in Columbia, and our hand therapy consultant tonight who's going to offer some words of wisdom, Scott Gould from Indianapolis from the Indiana Hand Center. Some basic housekeeping things just to attend to. All financial relationships have been checked, and then our validation statement for AO North America. All your microphones have been muted and the video cameras have been turned off. We encourage and love questions and encourage you to submit questions through the Q&A box. We'll look at those, we'll answer some live, depending upon time, or try to answer them within the Q&A box as well, but please don't use the chat box for this. Our objectives for learning shown here. And then our agenda tonight, we're going to have 4 small sessions with different topics, about 12 minutes or so each, followed by some therapy points. And then hopefully at the end, we'll have some time for some discussion, further discussion and questions. Hopefully have everyone out around 8:15 or so. This is our series. I mean, obviously tonight we're doing session 1, but the series will be weekly. The next Thursday, this session will be complications of tendon surgery with Dr. Bridgman and so on. And so please plan to join us. There are also some very interesting and educational courses coming up in Tampa, as seen here. So please kind of investigate those and look at those as well as some great webinars coming up starting on May 18th with nerve transfers by Dr. Hoyen. So please kind of look around and see what else we have to offer. This is being recorded tonight, and the link will be sent out through a Zoom about 24 hours after we finish. So look on YouTube for that. So that being said, let's just go ahead and launch into our first talk. I'm going to talk about the displaced volar lunate facet, also called the volar marginal fragment, or BMF. Dr. Orbe aptly dubbed this fragment the Achilles heel of distal radius fixation, and that is very true. I mean, so how does this happen? I mean, what is it that happens in this fracture pattern? Well, typically, an articular fracture pattern will separate the scaphoid fossa from the lunate fossa. And then a coronal plane fracture may further divide that lunate fossa into a posterior medial and an anteromedial fragment, as shown by Dr. Berger. Typically, the anteromedial fragment can be fixed with standard fixation, and so we don't think about it too much. However, if the fragment is too small to be easily stabilized by standard plating, we call this a volar marginal fragment. And I've shown just some representative pictures just to kind of orient everyone to what we're talking about. So it's a very small fragment on the volar ulnar corner. And this CT kind of shows how this small corner actually extends into the sigmoid notch and can affect DRUJ stability as well. And this nice 3D reconstruction again shows you that small fragment as shown here. So It is quite small, and it certainly doesn't look like it would be particularly important. So what is it about this that makes it so important and such a bad actor? Well, Dr. Jupiter has shown that the volar rim of the lunate fossa is almost solely responsible for preventing volar carpal translation. And why is this? Well, it's the ligamentous anatomy. So as shown here and kind of highlighted in red, the short volar radiocarpal ligaments and the volar radioulnar ligaments attach just to this very specific area of the volar lip that we're talking about. And this is what helps to stabilize our carpus volarly. So without this stability, we have problems. And it also, as I showed in that CT, it can involve the sigmoid notch, which adds to the instability of this pattern at the DRUJ. So one very small fragment can cause a lot of trouble. So what are the challenges coming in as we are looking at this? And what do we have to be careful to pay attention to? Well, the small size, as we said, so it doesn't look like a very big piece. Typically, if it is a big piece, it's actually just a typical fracture that we fix with our standard volar plating. So this is a smaller size, and the blood supply to the fragment may be tenuous, and it may become avascular, which further inhibits our healing and causes additional problems. The blood supply to this fragment actually comes in retrograde via the capsular attachments. So this is an important factor in the surgical approach and in kind of the fixation as well, to be mindful of that vascular supply. It can be difficult to recognize on radiographs. Typically in retrospect, after everybody knows when the carpus has subluxed, everybody can recognize that. And then you go back and look at the injury films and think, oh yeah, now I see it. But initially, it can be a little tricky. So just have to have a very high index of suspicion. It is somewhat uncommon, but it happens. And the displacement may be delayed, meaning that initially you may think everything looks good, the x-rays look good, and you think you've captured the fragment. And then 2-3 weeks later, in follow-up x-rays, you start to notice that something's not right and there's some subluxation, and realize that indeed the fragment wasn't stabilized. So all those challenges put together make this a very challenging situation. So I have a couple cases just to illustrate what we're talking about. So this first case is a 40-year-old female who fell during a CrossFit class, injuring her wrist. She initially went to an urgent care and they told her, oh, it's just a wrist sprain. And they gave her an off-the-shelf cock-up splint and said, give it a couple weeks and, it should get better. So she gave it 3 months and she presented saying, my wrist looks a little funny. It has a little curve to it that I don't remember, and I don't think my other side has, and it aches all the time. So as shown here, it's kind of like this little bit of a sag. So the distal radius looks a little higher and then it kind of sags, not to the degree of, an unstable DRUJ, but it's definitely a subtle clinical finding, but one that the patient notices. And if you look closely, you can see it as well. These are her presenting x-rays. And indeed, looking at this view, you can see that the articular surface just doesn't look quite right. Looking at the laterals, and this is the left side is her normal side, the right side is her injured side. And if you look kind of at the long axis of the forearm there, you can see that the right side is sitting just volar to where it should be sitting. So the lunate has indeed kind of slipped volarly. But again, you have to kind of be mindful that you're looking for it and be aware of that. This is just a representative CT, couple CT cuts showing her fragment. And you can see on this lateral view how the fragment is very small and often now she's, this is not an acute setting, so she's now united in a malunited position. But this is her fragment and her lunate has followed with that. And this just shows how that piece does indeed extend into the sigmoid notch. And here's her old fracture site. Some 3D reconstructions here are kind of interesting to look at, and I think they illustrate very well in a very nice way how this this volar fragment looks. I mean, like I said, you can see now that she's healed. position. But if we saw this acutely, this fragment would have been very small. I mean, so this is, like I said, like I mentioned before, this is something you have to just be very careful of, but you can definitely see how her lunate is now not properly reduced. So using an extended carpal tunnel approach, which I think is a very pertinent teaching point as well. You have to be able to do the right approach to see what you're needing to see in an acute setting or in an osteotomy setting. So the traditional volar radius approach is probably not going to be adequate. You're going to struggle. So I think utilize something like an extended carpal tunnel approach so you can get to where you need and you can see properly what you need to see. Because this was a malunion and I was able to fashion the piece, I could kind of I had a little control over the size of the piece. So I was able to use more of a standard plate to reduce that piece and reduce the sigmoid notch and get the radius aligned back as it should be with the lunate and the radius in good alignment and restore that axis. And she did well and returned to her activities, returned to doing her CrossFit and that. So that turned out well for her. The second case is a little different. I'll just briefly go through this just to illustrate some of these points. So this is an older female, 61-year-old, presented for a second opinion after having fallen on the stairs, missing a step. She had a history of osteoporosis and was already under care and being treated for osteoporosis. She initially underwent a closed reduction, which failed, and then she underwent surgery a couple of weeks later. And I highlight here, again, like if you kind of look back, this is that small, it's somewhat osteopenic and a little bit difficult to assess volar piece. And here's her ulnar styloid over on this side. So she had pretty dramatic instability of her distal ulna because of this pattern and of her carpus. So when she presented to me, she was about 2 months post-op, and she came in because she thinks her wrist looks funny. She doesn't know why it looks crooked. And she has this aching and this stiffness. And again, she had the obvious, that sag that I was talking about. So you can really see that clinically. She also had a dorsal unstable ulna and had no really active or passive supination. So her forearm rotation was quite limited. And if you look again, just assessing this critically, you can see that pretty much the whole carpus is volar to the long axis. So basically she has a pretty dramatic volar subluxation. Her CT, again, showing this fragment that's on the wrong side of the plate here in this view. And her DRUJ obviously is not well reduced. And this is a lateral view. I apologize, it is a little grainy, but this is the volar piece here. And her lunate obviously sitting not on the axis of the radius like it should. So we took her to the OR and basically removed everything and did a complete reconstruction to put her lunate back on her axis. Also, at the same time, doing an open reduction and figure of 8 tension band wiring of her non-united ulnar styloid fracture to reduce her ulna and give her some ulnar-sided stability. I chose, because of her osteopenia and because what I found, to do a bridge plate. And this is something we can discuss. I'm interested in maybe some of the other faculty may have an opinion, a pro or con on this. I don't know if I did this more for her or for my own peace of mind, but I decided to augment her fixation with a plate, and she did well. And she went on to be nicely restored with a functional range of motion. She was able to return to golf, and her DRUJ was stable and no pain. So that's kind of an example of how these fractures, both of these were chronic, meaning that they had been initially not appreciated. So you may see some that come in as a second opinion that may be very common. Just want to briefly wind up with fixation options. And I think this is important because there's not just one plate or one technique. There are many different things out there on the market, and there are very different things available. And I think it's wise to have more than one tool at your disposal. And when you go into the OR to do these, because it doesn't all, the fragment will tell you what you can do. And it doesn't always, lend itself to just one type of fixation. So kind of keep that in mind and have more than one. I mean, there's some interfrag, different fragment specific things. There's wires, there's Dr. Orbe has his hook plate, which can be very helpful. And as shown, you can kind of see how it works here and goes into that volar lip. So there are many plates, and then there are no plates, right? So these are just anchors. Somebody was, thinking that they wanted to use as an example, and some specific, certain plates that are engineered and designed to a certain shape to allow you to capture that volar fragment. So, I mean, there are many ways of doing it, but just make sure you have more than one way in your toolbox, because the fragment may surprise you and you might not give you just be amenable to what you think you want to do. So some takeaways: an uncommon fracture, but you have to have a high index of suspicion, and it can be a bad actor. Imaging, it may be difficult to see initially on x-ray. So I would have a low threshold to get a CT on these fractures. I don't get them on all distal radiuses, but I think if you suspect that you might have something going on, I think it's wise to get a CT, and that will be very helpful to better illustrate your fracture pattern. The fragment is small. It has a tenuous blood supply, so be cautious with your dissection. Try to preserve your capsular attachments if you can. The approach, make sure you have an approach that you can see what you need to see. So don't hesitate to use a carpal tunnel approach and kind of extend it so you can see. And then have, like we said, have those fixation choices available to you, more than one, so that you can kind of flex and bend depending on what the fracture tells you it will do. So, Scott, some therapy considerations, if you briefly want a minute or two just to make your comments on what you think, and just some thoughts. I mean, when, given the complexity of these cases, when would you, want to start therapy? Would you use a different protocol, or would you use a protocol that's similar to what you would use for a standard distal radius, and splinting options? So yeah, if you have any thoughts on that.
Yeah, thank you, Dr. Mazzara, and thank you to AO North America for having me back. It's a pleasure to be with you tonight. My name is Scott Gould. I'm a therapist at the Indiana Hand to Shoulder Center. So regardless of the type and severity of distal radius fracture and fixation technique used by the surgeon, I think it's important for therapists to understand the difference between these injuries and how to rehab them accordingly. So with volar lunate facet fractures, loss of reduction in carpal subluxation can occur due to the difficulty maintaining a reduced position due to the anatomy and the comminuted nature. Jupiter et al. Observed that the majority of volar shearing fractures have 2 or more small marginal articular components. So as therapists, we need to recognize that in how we're progressing these patients. We may be a little bit more cautious with these than we would just a cut and dry distal radius fracture with plate. Anytime I think a volar plate approach is used, we want to watch for FPL adherence. I think it's a thing that young therapists can often miss, where they have no IP flexion pulling through, and so that's definitely one thing that I'll look out for early on. And regardless, I think good education on the therapist part is critical for these patients doing well. We want to start them early, even if we're not moving the wrist. I want to start them, a week or so out from surgery, go over edema control, go over their digital exercises, and make sure they're not just wiggling their fingers, making sure they're getting good excursion for the flexors and the extensors to get those tissues moving.
Great. Thanks, Scott. So I'm going to stop sharing. Dr. Bridgman.
So in continue on with that theme of the anatomy, and my topic is on dorsal instability in contrast to volar instability. So the dorsal instability that can lead to complications in distal radius fracture treatment is even more rare than the volar ulnar corner. It's estimated to be between 0.5 and 1.6% of all distal radius fractures. But there's just less description, less studies in the literature to guide decision-making. And so this can be challenging. And, one of the common things that is seen is, just like Dr. Mesra described the volar subluxation, is looking at that carpal alignment and the long axis. So this is related to the column theory, and that just as the volar ulnar corner that Dr. Mesra described as that volar aspect of the intermediate column, the column theory is kind of helpful when you're thinking about the different fragments of the distal radius. And this description by Dr. Medoff and Peter Reed and their authors is a very helpful article from 2017, just describing some of the major consistent fragments that you'll see, or themes of the fragments that you'll see, including not just the volar ulnar fragment, but dorsally, they'll have the dorsal ulnar corner fragment, dorsal rim, central dive punch, and then the radial column would be the radial styloid. But the key is that when the intermediate column is affected, that can lead to instability of the carpus. So you have abnormal carpal alignment, which we saw in the last talk, as well as abnormalities in the DRUJ alignment. And it's often helpful to think about the central axis of the capitate, that the capitate central axis should line up with the volar cortex of the distal radius. And so we saw that in some of Kim's cases, and even in these radiographs here on the right, you can see a white dot in the capitate and then how far dorsally subluxated the overall carpal axis is compared to that volar cortex of the radius. But this is an axial pattern of instability. It's an axial failure. And so you'll see comminution, including this dorsal ulnar corner fragment, dorsal wall or dorsal rim fragments, and then the central dive punch. But all of that bony architecture fails with dorsiflexion mechanism and impaction, leading to the loss of support for the dorsal the carpus, leading to dorsal subluxation. And then on the other side, because that's not only affects the radial carpal joint, but also the distal radial ulnar joint, you can get DRUJ instability. Sometimes you get instability of the ulna, but sometimes you can get a bony block, as you can see in this CT axial view, that there's a bony fragment that can lead to a bony block of motion. So also considering the attachments, just as Dr. Mesra talked about the volar ligament attachments, well, it's very similarly dorsally, that the dorsal ulnar corner is also the attachment of the dorsal fibers of the distal radial ulnar ligament. And it also is a contributor to the bony architecture, which is a bony constraint, as you will, to the ulnar head. The dorsal wall fragment is the attachment of the dorsal radial carpal ligament. So I've outlined those in red here on the anatomical picture on the right. So the DRC, dorsal radial carpal ligament, and then the horizontal one is the dorsal fibers of the distal radial ulnar joint ligament. And then the central dive punch often contains a large section of the lunate fossa. So that's why you get subluxation and instability of the lunate. But also, just as a reminder, it can include portions of the scaphoid fossa as well. Now, these all contribute to the concept of what approach would you need in order to address dorsal instability. And these can often be in combination. So you could have a volar ulnar fragment as well as a dorsal ulnar fragment. And that's where I think that the CT scans can be so helpful. Not only can you get information about the different combination of fragments that are affected. For example, if there's a dive punch fragment, will that need to be reduced? Will you need to maybe do bone grafting underneath that? But how many approaches may you need? Could that all be done with one approach? So one concept that comes to my mind is, for some standard distal radius fractures that have a dorsal ulnar corner fragment, it may be minimally displaced. It may be a larger fragment that a standard volar locking plate fixation strategy would still be sufficient, and that you could incorporate your fixation strategy from a single volar approach. But often in a area where there's a displaced dorsal ulnar corner, it's a very small fragment that's difficult to capture with volar screws. If there's displacement that is involved in the distal radial ulnar joint, that's where I think a more direct approach to that dorsal ulnar corner fragment would be helpful. certainly to look at and inspect the articular reduction itself is better done through a dorsal approach. And then when I think about what dorsal approach would I use, if there's a radial column injury, I am often trying to create a larger skin bridge. So I may do a radial styloid approach for the radial column, and then in order to make a larger skin bridge, I may do a fifth dorsal compartment approach if all I'm needing to do is add fixation for the dorsal ulnar corner. Certainly just a standard central approach through the fourth dorsal compartment can be useful, but then you get a kind of a narrower skin bridge between those if you're doing the radial approach as well. So all of these things can be kind of delineated more, I think, through a CT scan, especially if there's significant comminution and displacement. If there's involvement in the distal radial ulnar joint, I'm suspecting that I'd like to get a CT scan to evaluate those fragments. And many of these, require a combined approach as I described. So the operative plan, in this discussion point, I just went to what I would call principles. You really need to, and Dr. Mesra discussed this as well, is that you have to have a lot of tools in your toolbox in order to address highly comminuted and distal radius fractures. The volar fixation, Dr. Mesra has already kind of described that, so I'm not going to go into detail with that. So I'm just going to really focus on dorsal fixation strategies. But we talked about, thinking about a skin bridge and how wide of the skin bridge you have between approaches if you've already planning a radial approach. So that's often where I'll do a more ulnar dorsal approach that's through a fifth dorsal compartment approach. If there's a die punch, I really need to see more of the joint itself. So that's where going through the fourth dorsal compartment allows me to get both the dorsal ulnar corner as well as inspecting the articular surface through a dorsal capsulotomy. Often there's a metaphyseal void that can be used to graft behind and support the die punch after it's reduced. Don't forget that the dorsal ulnar corner fragment may also need to be inspected in order to make sure that you've achieved a reduction of the dorsal aspect of the DRUJ or the sigmoid notch. And many of these may not, if it's a larger fragment, it may not need a lot of fixation in the fragment itself. It may just need a buttress from the plate. But the smaller the fragments are, the more difficult they are to capture, just like the smaller fragment of the volar ulnar corner that Dr. Mesra discussed. And so that's where I think, being familiar with fragment-specific fixation can be really helpful. And then lastly is it possible that the ligaments that are associated here may be torn? So some of these are kind of in a spectrum of radiocarpal dislocation or a DRUJ dislocation. And so for example, the dorsal distal radial ulnar joint ligament is incompetent or is torn. And so I'm always thinking about maybe I'll need an anchor, for example, or some type of strategy in order to repair those ligaments. Now, this is a study, the Zimmer study in 2020 in Journal of Hand Surgery is one that I contributed to, which is a retrospective review of CT scans of 80 patients that had intra-articular distal radius fracture. And these were older patients. They were older women who were postmenopausal. But the main idea of the analysis of the CT scan for these fractures is that these are often very small fragments, that the average size was less than 5 millimeters of the dorsal to volar articular segment. And that represented a less than 25%. So it's approximately 24% of the dorsal volar articular surface. So they can be very small. And so the kind of the learning point or the teaching point of that information is that if you're going to be choosing a volar locking plate, for example, if that's the fixation strategy that you've chosen, you're going to need longer screws in order to capture that dorsal ulnar corner fragment. If you can't capture that successfully, you just need to incorporate doing a separate approach dorsally in order to get fixation on the dorsal side. It's helpful to have backup plans. I thought that was a great case that Kim showed of the dorsal spanning plate. And I think of that as well, that some of these are so unstable. They're in a spectrum of a radiocarpal dislocation. They can be very unstable. And so if you feel like your fixation needs to have some additional protection, either using the external fixator or including a dorsal spanning plate, I think that's a great idea. Certainly, if their bone quality is poor, that's a contraindication to fragment-specific fixation. But having multiple tools at your disposal in order to address these is important, including anticipating you may need to do ligamentous repairs as well. The post-operative protocol changes. I don't have a lot to add to what Scott already said. I've got some questions at the end of my talk for Scott to kind of contribute to, but this is just one study that comes to my mind. Is from 2008 by Calderon, where they compared patients who had distal radius fracture internal fixation to a 2-week early motion protocol versus 6-week, and their total wrist arc of motion was no difference at 3 months or 6 months. But the key was early digit range of motion in edema control. And I think as a hand surgeon, we all have those patients that get sent to us that have had treatment, had stiff fingers from the very beginning, and now they're at 6 weeks, even 10 weeks after their surgery, and they're so stiff, they have not had adequate therapy. So it's really, sometimes this is kind of a digit emergency, like the fracture's been treated, but their hand is so swollen that they really need to be in therapy. What about outcomes? Well, specifically, this is one paper that I could find on these dorsally unstable intra-articular distal radius fractures. It's a retrospective review of 20 patients, a mean follow-up of 30 months. These were mainly type B and C fractures, and 14 of which had central die punch involvement. At their follow-up, half of patients had pain with activity, so significant ongoing pain. Their motion scores I thought were reasonable for the type of comminuted fracture pattern that they have. And then in the radiographic analysis, one patient had ongoing dorsal carpal subluxation. 5 had a radiographic evidence of arthritis. And then for their Mayo risk scores, a significant amount were, even up to half, were had fair or poor pain scores. So significant ongoing issues with these types of fractures in their outcomes. So what's the unsolved issues? We just don't have good data. We need better prospective studies, and that chondral injuries, even in that paper, there were chondral injuries where they had osteochondral fragments that could not have fixation. They were just shear injuries that they were removing chondral pieces. And so you can have significant ongoing issues from that. And then the take-home messages, dorsal carpal instability, just understanding pattern identification, carpal subluxation. CT scan evaluation is important, especially if they're highly comminuted and you're trying to get better analysis of the size of the fragments, as well as the involvement of the DRUJ. Being comfortable with multiple surgical approaches, from that extended carpal tunnel approach that Kim discussed, radial styloid approach, dorsal approaches. I tend to think of the surgical technique as making a to-do list. It's like keeping in mind all of the things that you may need to be addressing and having a plan for each of those, and certainly including a backup plan. And that long-term wrist stiffness and arthritis are common. These are my references. So just for Scott, I'll go ahead and stop sharing. But Scott, the question I had for you, knowing that these can have need multiple approaches, they've had multiple incisions. How do you incorporate that as you see, maybe it's a person who's had that versus just a volar distal radius fixation? What comes to your mind? What are strategies that you're incorporating in someone who's had, 3 approaches on one wrist? They're fairly swollen. What do you think about that?
Yeah, certainly early edema control and motion is critical for those patients. But the other thing that comes to mind is watching for early extrinsic extensor tightness, especially in terms of recapturing composite wrist flexion if they've had a dorsal approach. I think that's something that you really have to be cognizant of. I make actually a dynamic wrist composite flexion splint that works wonders later on, once everything's looking pretty good on radiographs. And I think one thing I'll kind of shoot back at you is I was looking at some articles today, and I thought this was interesting. There was an article from Zhang and colleagues from June of 2020 titled Volar Splitting and Collapse Type of Die Punch Fracture Treated by Volar Locking Plate, a Retrospective Study. And they discuss casting patients postoperatively for 4 weeks. And I wanted to get your thoughts on that. I feel like we don't do a lot of postoperative casting for these at the Indiana Hinge to Shoulder Center. So
yeah, I try not to, if we've had sufficient fixation, I try to avoid a cast if I can, but certainly, in mid-Missouri, I've got people here who ride, horses, and, you can't trust them. And so I use a cast for people I don't trust. But digit motion, honestly, at a year, if they have great digit motion, they're going to be happy with their outcome. And so that's what I'm really worried about initially. So I'm not as worried about a cast early on, but I'd like to get them out of the cast as soon as we can to incorporate the wrist protocol. And I really like that composite dynamic splint that you're talking about. I've not used that. And so I think that sounds really interesting to me.
Yeah, it's a fun one to make. I think the other kind of short point here I'll make is the understanding the anatomy. So like you were talking about with the die punch fractures, with the lunate fossa accounts for 46% of the distal radiocarpal articular surface and is the predominant weight bearing and axial load transfer area. So I think especially with these patients early on, we definitely don't want them weight bearing, but we also don't want them tightly gripping and creating that axial force through the carpus.
Sure. Thank you.
Thank you, Dr. Bridgman. That was fantastic. And Scott, thank you for your comments.
Kim,
Next, Marco, do you have a comment?
Do you have a minute for just one quick question, since you and Jay both brought them up? One of the questions from an audience participant was, when do you decide to take your bridge plate out? What's your preferences, each of you?
Jay, if you want to go first, you can go ahead.
Yeah, some of the like hardware removals are just trying to find time on my OR schedule. And so oftentimes it's about somewhere between 10 and 12 weeks. I guess it depends also on the patient. So if it's an older patient who's osteopenic with poor bone quality, I might really wait until they're at 3 months to wait so that I know that everything is really solidified before I take it off. What do you think, Kim?
Yeah, I would echo that. I tell the patient when I'm going in, and I always counsel them that there is a possibility that we may have to have an additional procedure in 3 months. And I use 3 months. 3 months isn't set in stone. I mean, I may go a few weeks earlier, a few weeks later, depending, but I don't like to go much more than 3 months. They just get so stiff, right? But I think 3 months is what I counsel the patient. And then we kind of decide what works best for both of our schedules. So thank you, Dr. Bridgman. That was fantastic. Next, we have Dr. Gupta, who's going to talk to us about the DRUJ.
Well, thank you, Kim, and thank you to the committee for inviting me. My job is to talk about the DRUJ, and oftentimes you have a distal radius fracture. Even if it's a simple distal radius fracture, it may heal well, and then patients will complain about the distal radial ulnar joint or ulnar-sided wrist pain. So this is the back pain of the hand or the wrist. So let's look at the anatomy. Anatomy is very unique because you have the triangular fibrocartilage, which is the which has two attachments. So there's a superficial part which is attached to the tip of the styloid, and then there's a deeper part which attaches to the base of the styloid. So you can imagine that if you have a fracture through the tip of the styloid, that fracture is not going to be as destabilizing of the distal radial ulnar joint as you would have a displaced fracture of the base of the styloid. So if you have a fracture of the radius which is displaced towards the radial side, and along with the fracture of the base of the radial styloid, so obviously there is a considerable instability of the distal radial ulnar joint. So this shows the volar ligaments, as we've been talking about, the volar radiolunate and radiocarpal ligaments, and this shows the dorsal ligaments and the TFC, the two parts, the superficial part and the deeper part, and the ulnar head, as well as the sigmoid notch. A little bit more detailed view of the dorsal part and the two parts of the TFC, the superficial and the deep part attaching to the base of the styloid, ulnar styloid. And very close relationship to the ECU, the sixth compartment tendon, and the subsheath, which is very closely related to the triangular fibrocartilage. So in most instances, we are faced with fractures of the radius in different configurations, but they may be associated with different types of ulnar styloid fracture. Generally, once you get a good reduction of the radius, then this ulnar styloid becomes quite stable and reduces, and you hardly ever need to do anything dramatic for the ulnar styloid. I try to avoid doing anything on the ulnar styloid, because putting in pins or screws or plates on this side, is for some reason the ulnar styloid does not like it, and the patient will complain of that more than anything else. So good reduction of the distal radius. So make sure that it's not translated towards the radial side. If the radial fragment is translated, then you don't have a good reduction, and that will give rise to instability in this joint. But if you have a good reduction, you reduce everything will fall into place. So if you have a reduction, you really don't have to use big plates and screws. This is an extra-articular fracture, and you can see the styloid reduces very nicely, and we didn't do anything to the styloid, just goes on to heal on its own. Sometimes they cause problems, and if you have your distal radius heals, but there is instability, there is a prominence of the ulnar styloid, then obviously people have tried to do ligament reconstruction. In those instances, if the situation tells you that it's not, the instability is not really corrected, then ulnar shortening, which will tighten the ulnar carpal ligaments, is a good option, along with taking out this grossly long ulnar styloid. So if you remove the ulnar styloid, at that time you can do an ulnar shortening, and that will give you tightening and stability of the distal radial joint. If you have a frank malunion of the distal radius along with a ulnar styloid which is causing problems and instability, then correction of the deformity itself may be all that's needed. You may or may not have to fix the ulnar styloid, and here just the correction of the deformity results in excellent function for the patient. If you have continued instability due to a malunion, as I said, a good correction of the malunion will result in stability. And it's been shown clearly that if you correct the malunion of the radius, the ulnar styloid attaches and heals pretty well. And as you can see, just the correction of the malunion has resulted in healing of the ulnar styloid fracture, ulnar styloid non-union. So this is just showing the different attachments of the TFC and in pronation and supination, and here again. So this is the TFC, looking at it from the top, the part of the TFC and the dorsal and the volar parts of the TFC. And in most instances, if you need to fix it, you do it arthroscopically, and you can do a peripheral repair of the TFC. Now this shows very nicely what I was talking about biomechanically, that if you have separation, a fracture of the radius, and it shifts radially, and then you have an ulnar styloid fracture at the same time, this will result in instability of the distal radial joint. And this is what you want to avoid. You want to reduce this very nicely, and then this will realign and hopefully heal. If you have situations like this, when this is gone into malunion like so, and there is ulnar abutment, ulnar is high, it's not aligned to the sigmoid notch, there is non-union, then you have to do a much more aggressive correction in terms of osteotomy of the radius and ulnar shortening at the same time, resulting in restoration of function, pronation, supination, etc. More aggressive correction of intra-articular malunion, realigning the sigmoid notch, realigning that fragment that you see here will result in stabilization and good restoration of function. And here again, you can see the restoration of function in this patient. Now, there is an ulnar instability due to plastic deformation of the radius. This is slightly off topic. I just want to mention that people have had fractures of the radius when they were a child, then they have a trauma, and then you see a plastic deformation of the radius and a distal radial joint instability causing pain. And the thing to do is take a big leap of faith and correct this radius, and you will see that the ulnar styloid will realign itself, and it will result in good stability and relief of pain and restoration of function for this patient. Many times you'll see that the patients have had this operation, the Drej operation. Younger patients generally will not do well, and people have tried various means of stabilizing the stump of the Drej with tendon transfers or the Bowers procedure, etc., or even one bone forearm, which is, I think, a dreadful operation in my opinion. The reason for problems is that the radius in the ulna, we tend to look at the radius in the ulna in the hand in this position because that's how our x-rays are taken. But in load-bearing position, it's the hand in this position, which and the patient bears load. That's how it's there functionally. So if you have a distal ulna which is not stable, then the patient is asked to bear load. The radius and the ulna come together, and you have radio-ulnar impingement. This was shown very clearly by Vivian Lees and Louis Schecker. You take x-rays like that, gripping over weight, and then you can see that radius and the ulna will come together when this Drej or even ultra-short Drej has been performed, and the radius and the ulna will come together. People have tried to do various ways to prevent this from happening, and Dean Sotrianos had this allograft putting in between the radius and the ulna, tried to stop this from happening, and here is a situation where this was done. But the most consistent way I think that we have been able to achieve relief of this symptoms from this problem is this Schecker's DREJ implant. It's a little aggressive, but if you have a big problem like this, there is no other option that better than this, and it works very well. Now, if you have instability, which is related to you've done all the skeletal corrections, but you have a true ligamentous instability, then you have to think about ligament stabilization. This is Louis Schecker's correction of the dorsal radioulnar ligament. It's a little complicated way to do this, and it's been detailed very well in an article that was written by Dr. Schecker, and this gives rise to very stable distal radioulnar joints. If you look at green, there are a whole bunch of ways of doing things, which tells you that either all of them work or maybe none of them work. This is again Schecker's work from the journal. Then there's the Adams reconstruction, Berger-Adams reconstruction, and where you have to make a drill hole from the dorsal or volar to the from the dorsal side to the volar side, and pass a graft, usually palmaris longus, and then this goes and forms the volar and dorsal radioulnar slips, and this goes to the ulnar styloid, and you fix it to the ulnar styloid. So you go like this and pass the tendon graft, and then they come across and fixes here, just like that. Now there's a little bit, I do a little bit different BR wrap. I take a brachyradialis, leaving it attached to the radial styloid, and bringing it across over the extra anatomic, like over the ulna, and fixing that. So what we do is do a soft tissue stabilization, taking the brachyradialis tendon. So you have to take a long segment of the brachyradialis tendon, make two small incisions, one distally, one proximally, distally over the first compartment and proximally at the musculotendinous junction, and tease out the muscles and take a very optimal length of the tendon. So you have to find the dorsal sensory branch of the radial nerve, which is between the brachyradialis and the ECRL. So you tease out this muscle fibers and take out a long length of this of this brachioradialis, leave it attached to the distal part of the radial styloid, and this is showing in the drawings. And then you can come across over the ulnar part and stabilize that. So I'll go through the drawings, and then you bring it deep to the pronator quadratus. So it is lying on the radius on the volar side, and it's again lying on the radius on the dorsal part, deep to the extensor tendons and around the neck of the ulnar. So it's an extra anatomic reconstruction, just like a watch strap, and it stabilizes and sutured back to the radial styloid. So it's just like that. So deep to the pronator quadratus, around the ulna, and then deep to the extensor tendons, lying on the radius on both sides, and then sutured back to the styloid. You'll run short of the tendon if you don't tease out the muscle, because you can increase about an inch or so of the tendon length by teasing out the muscle. So here's an example of a patient who had arthroscopic repair of the TFC after distal radius fracture. Then that failed. Then he had an Adams reconstruction, and that failed. And then I saw him after that. So you can see. So you can see the.
Oh yeah. Oh yeah.
So you can see the. You can see the instability of this DREJ, and this is him. This is having a brachioradialis wrap, and then you can see that's immediate stability following the brachioradialis wrap. I put the patients in 4 weeks in a sugar tongue type of a splint and get them going after that, and this is in follow-up, and you can see that very stable distal radial joint. So, and here I'll present to you instability on the ulnar side. This is the mother of all instabilities, as I call it. Here's the patient that I encountered. This is a patient who had very severe fracture, intra-articular fracture, and as you can see on the x-rays and on the CT scan, the ulnar side is completely dusted. There's no ulnar side of the radius. The intermediate column is all gone. And when I opened it, it was all dust. The whole thing was dust. So I was at a loss of what to do. So basically, at that point, there's no sigmoid notch. So what I did, I took out the distal ulna and shifted it and made it an articular surface for the wrist, and put a plate and screws across there, and made this into a Drej, which was like this. And here's the end result for this patient. She got absolutely excellent result and maintained for over a year now. So thank you very much. We've gone through some of the problems of the ulnar side of the wrist, and I hope I was able to show you what we can do with the ulnar-sided problems. Thank you.
Thank you so much, Dr. Gupta. That was fantastic. I just love, I love listening to your talks. It was great and fantastic pictures. Scott, you know, this is a lot of stuff, and it's a huge topic, but do you have any, I mean, are there a few things or things that you would kind of like to just to mention as salient points that might be helpful for our audience?
Yeah, absolutely. I really liked your analogy, Dr. Gupta, that ulnar-sided wrist pain is the back pain of the hand and wrist. I find that these patients really, with instabilities, can really appreciate a well molded splint and or brace. And this population is one that's not participating in activities of daily living or recreational activities and things that they enjoy because they have so much pain on that side, and they don't want to use their hand, especially with gripping activities. And I think another thing to mention is that the associated secondary weakness in the wrist and hand is a big problem with these patients too. It needs to be addressed because they're going to lose quite a bit of grip, even if they have a salvage procedure.
Yeah, that's fantastic. Dr. Gupta, do you have any other comments?
No, I think everything is pertinent. I usually when there is an ulnar-sided problem, and I've dealt with the ulnar-sided problem, I usually put a sugar tongue splint and I immobilize these patients for 4 to 6 weeks. In that, I allow them to come out of the splint, have their elbow motion, and then I will get the wrist motion, but prevent pronation, supination for a while till all that heals up.
When do you feel comfortable allowing them to have active supination pronation? I mean, what's like a ballpark for that?
So if I'm doing a reconstruction, or even if I'm doing an arthroscopic repair of peripheral TFC, 6 weeks is what I'd go for.
Do you do any any special splints that you would use for this, or do you have anything custom that you do?
Absolutely. I mean, there's lots of options if you have stiffness with supination and pronation. There's some good braces on the market. Statidyne and Joint Active Systems come to mind. There was also an article a while back that talked about changing elbow position in terms of supination and pronation. And they found that if you in a more elbow flex position, there's more space at the PRUJ, which allows for more supination. So that's kind of an exercise modification that I'll make a lot of times, is instead of having patients down at 90 degrees of elbow flexion, if they're limited with supination, I'll have them flex their elbows. There's an exercise I call the patty cake against the wall. And then conversely, if they're limited with pronation, if you increase extension of the elbow, you increase space at the PRJ and allow for more pronation.
Excellent. Well, thank you.
Kim,
Thank you very much.
I just want to make one point.
Yes.
I have a particular dislike for doing one procedure, which is pinning the distal radial ulnar joint. That just shows the total, lack of, application. So you should not pin the distal radial ulnar joint. In no cases do you pin the knee, put a Steinman pin through the knee, or so we should not be doing that. We should be looking at what is unstable and reconstructing it, and not putting pins willy-nilly. The other thing is that you have to protect the repair. Whatever repair you do, you have to protect it for a while, let it heal, and then go on to mobilization.
That's great.
I think that's a great point, Dr. Gupta. I have had so many difficult cases where they were pinned wrong, scarred in, the DREJ is not reduced, and now I'm at like 8 weeks trying to like take that apart and try to get it. If you need to fix the DREJ, just fix what's wrong with it. Don't pin it.
I know. It's true. I mean, I find the same thing. I think people are kind of afraid of the DRUJ and they don't know what to do, so they just pin it and then
I tell the residents I work with, if you don't know what's wrong with it, that's okay to pin it for the call night, but then call your hand surgeon the next day and say, I had to pin a DREJ last night. Can you take over and fix it? Don't wait like 3 months or 6 weeks.
Good point. Good point. Dr. Gupta, thank you so much. Thank you so much.
Thank you.
Dr. Rizzo, you're up to kind of wind up our talk with some talk about nerve issues.
Oh, thank you, Kim. Can you see that okay?
Oh, yeah.
Thanks so much for the, oh, sorry. I'm going dyslexic here. Thanks again for the invitation to participate. And my charge is to speak a bit about pain, particularly is it CRPS or carpal tunnel or both. And I guess if the ulnar side of the wrist is the low back pain, then this must be the low back pain, if you will. And I have no relevant conflicts related to this presentation. By way of a case example, this is a 43-year-old female who fell in the parking lot, and in addition to this displaced fracture intra-articular, she also has significant numbness and tingling. And I thought we could use her as a case example and discuss how we would approach this in terms of dealing with both her fracture as well as her neuropathy. Her exam revealed significant numbness in the median nerve distribution. She had pain at the wrist, deformity, as you can see, limited finger flexion extension. Her 2 point in the median nerve distribution was greater than 12 millimeters, and then the ulnar nerve was about 5 to 6 millimeters. So what we're dealing with here is what we're talking about is acute median nerve problems in the setting of distal radius fracture. And there's nice evidence-based medicine article from, I think it was 2015 by Phil Blazer and his colleagues looking at this. And the question is a relevant one in terms of what's the optimal management of median neuropathy in the setting of a distal radius fracture. The incidence of this is sort of all over the place, but we sort of can consolidate it to about 0.2 to 21% of cases. And I sort of outlined some important questions to consider. The degree of displacement has been linked to these. Whether or not they've had a prior history of carpal tunnel, I think, is a really relevant question. And what exactly is their baseline pre-injury? I think the exam is critical in terms of us getting a sense of the real objective measures of median nerve dysfunction. Now, a lot of folks will complain of numbness and tingling and have a 2-point discrimination of 5 millimeters, and some won't complain as much, but their 2-point is actually through the roof. So there's a subjective component to this that makes it a little harder for us to assess. We're not just measuring angles and trying to determine the anatomy. We're dealing with pain and numbness, which can be subjective. And one of the more important points is what's the progression of symptoms? How long has it been since the injury? Is it getting better? Does the reduction help, or did the reduction make it worse? I do feel that when you're reducing this, it's important to not use a Marcaine injection for the hematoma block. I would strictly use lidocaine, get the reduction, and then you can really assess their exam again much more quickly than you would, just in case the Marcaine and lidocaine leak over to the nerve and really blunt it. This is also important in the sense of following after treatment, following surgical treatment. And also these kinds of questions in this assessment will help determine whether a concomitant carpal tunnel release is necessary if you are going to be treating it surgically, or if a carpal tunnel release is necessary and then piggyback surgical fixation and have the carpal tunnel be the driving decision for surgery. When we look at predictors of acute carpal tunnel, you can, there's been some science looking at this. Itsubu and colleagues looked at 105 patients with distal radius fracture and acute carpal tunnel, and they sort of identified high-risk individuals, younger folks, males, tend to be more at risk. Unlike CRPS, males are more at risk of acute carpal tunnel than females. High energy injuries and AOC3 type fractures were noted to have a higher incidence, which obviously goes hand in hand with the high energy injury. However, Vanek and colleagues didn't see any link between carpal tunnel and the AO fracture fixation type, so there's some debate there. Dyer and colleagues out of the Mass General looked at 50 patients with acute carpal tunnel and 50 masked cohorts, and they found that young males, higher injuries were more associated with acute carpal tunnel. When they looked more specifically at multivariate analysis, predictors for developing acute median nerve pain, fracture translation was really the only risk factor. If lateral upper extremity trauma, multi-trauma patient reached near significance, but not really true significance statistically speaking. Well, the first step in these patients is to reduce the fracture. And this is, I think, something that needs to be done urgently. So I would encourage an urgent reduction and then reassessing at that point. If the symptoms progress or persist following reduction, then you may argue that surgical treatment is warranted, especially if it's gotten worse. After you've really been able to determine that it's not related to the hematoma block. And I think this is really relevant in patients with the absent or really grossly egregious 2-point discrimination and exam. As you might imagine, there's a gray area. If they have a milder deficit, this might be observable. If it's static, it might be observable. And therein lies a little bit of the art of dealing with this, in my opinion. When we look a little bit closer at complications, the median nerve problems associated with fracture fixation, and this was a large series looking at nearly 600 volar plates, and they found a 4% early complication rate and 7% later complication rate, and highlighted some factors associated with complications. And this was looking at all complications, but nerve injuries tend to occur about 2 to 8% of these patients, and it can be multifactorial. It could be combined factors, could be related to compression from the fracture, or aggressive or inappropriate traction, tenosynovium edema, hematoma, scar adhesions, or frank injury, iatrogenic injury. I don't know that this was ever published. One of our former residents, Hilary Becker, looked at this from our experience and noted that our complication rate with 153 distal radius fractures, this was way, way back ago, it's almost a decade ago, or if not longer, was a 28% complication rate, of which 17 of 43 sensory disturbances were appreciable, and the lion's share of those were median nerve. When we look at another series from Boston, looking at 100 plates, 57 dorsal and 47 volar, and sort of alluding to which ones are higher risk, pretty much volar plating is the higher risk associated with neurologic problems compared with dorsal plating, as you might imagine. And of course, the dorsal plates carry the risk of potential tendon irritation more so than the volar plates. This is a series out of Duke looking at external fixation and volar plating in C2, C3 fractures, and noticed a higher complication rate in ex-fix. Volar plates did have, however, more tendon and more median nerve complications. And in their series, I believe it was up to 5% in the volar plate group versus 2% in the ex-fix group. So that begs the question, is there a role for prophylactic carpal tunnel release in these patients? And it's pretty controversial, but the short answer is, I think, no. In fact, it almost seems that if we prophylactically treat carpal tunnel in these patients, that we sometimes find that they're actually worse off. So prophylactic carpal tunnel in a study of Udamala showed a 2.7 times increased risk of developing median neuropathy. And Lotman and colleagues looked at 2 cohorts of volar plating and found that there was less median nerve dysfunction in the group without prophylactic carpal tunnel release. Of course, you can see delayed carpal tunnel syndrome. I'm talking weeks and months after fixation, can be associated with malunion, residual displacement of the fracture components, edema, flexor tenosynovium, scar tissue, callus, and prolonged immobilization with the wrist inflection. And this incidence also sort of varies all over the place from 0.5 to about 22%. And most of us agree that it seems that many of these can be treated conservatively with splinting, but carpal tunnel release and hardware removal would be, I would have a low threshold for doing that after they've healed and if they're persistent and not improving with conservative measures. So as you summarize carpal tunnel, there seem to be related to higher injuries, gross deformity, younger patients and males. And I do think symptomatic and particularly progressive carpal tunnel does require an urgent decompression. And while you're there, fracture fixation is easy to make an argument for. Prophylactic carpal tunnel is not recommended. Currently, splints should not place the wrist in too much flexion to invite increased carpal tunnel pressures. And delayed presentation of carpal tunnel should be treated initially with conservative measures and with a low threshold for hardware removal and carpal tunnel release if needed. My next dovetail is to talk about complex regional pain syndrome, which often can be linked to acute carpal tunnel. So as we think about pain, and CRPS obviously is a terrible problem for patients. That can be long process, and the prognosis remains very guarded for good function, and it's a long recovery, even in the ones who we can treat successfully. There were studies looking at the use of vitamin C, and I'll go over that in some more detail. And there's some more debate now about that, whether there's use for it in the prophylactic setting, even though I still obviously discuss it with patients and recommend it. There's really no downside to it, I think. But this was a nice study looking at a summary of complex regional pain syndrome from Peter Reed, one of my colleagues, and Lauren Dutton, who's now in Jacksonville. And again, the incidence is sort of all over the place, you know. It's been reported to be anywhere from 1 to 51%, versus 4 to 8% in the general population. So there does appear to be certainly a link to the trauma being very in this particular setting, often I think related to a concomitant nerve injury that is smoldering and flares and creates a significant and complex problem for the patient. The Budapest criteria for complex regional pain syndrome, I won't belabor too much, but looks at 4 categories: sensory, vasomotor, pseudomotor, and motor trophic. And looking at those all four of the following criteria must be met. 1, the patient has continuing pain that's disproportionate. The patient demonstrates 1 sign of at least 2 of the categories below. The patient reports 1 symptom in at least 3 of the categories below, and there are no other diagnoses that better explain the patient's presentation. Acute carpal tunnel can result in some of these symptoms, so therein lies sometimes this idea that it serves as a fuel for the CRPS. And, important to delineate CRPS 1 versus 2. 1 is associated with a noxious event, but CRPS 2 is associated with a defined nerve injury. So that's important to keep in mind when you're thinking about these patients. And I think sensitivity about this condition and a heightened awareness of this possibility is critical. The sooner you get these patients into therapy and you get them going into the treatment algorithm, the better off they're going to be. Sometimes it's obvious. Sometimes it just looks like CRPS. They got allodynia, they got shiny skin, they got swelling, they got pain way out of proportion. But sometimes it's more subtle. Sometimes the diagnosis is not as straightforward, and this is why I think that the incidence ranges all over the place. Some of those early studies looking at vitamin C had enormously high rates of in my opinion, higher rates than what I've seen in my experience of CRPS, and their definition of CRPS may be different than what other institutions' view of CRPS would be. My level 5 guide looking at this is if you have having a heightened awareness of pain in these patients is critical. Getting a sense of their pain, getting a sense of if it's out of proportion. Now, granted, when you're young in your career, it's hard to tell, but as I've gotten older in 20 years, I can get sort of my spidey sense tingling when their pain seems to be out of proportion for what we're seeing in these patients. And oftentimes, these patients that I've seen, they catastrophize the injury. They almost have PTSD from the trauma or the reduction or the surgery or all 3. So this is something to me that heightens my awareness and concern about this. Neurologic signs and symptoms are obviously very important. Finger stiffness, particularly even early, is something worrisome. At 2 weeks or 1 week after the surgery, if they're having trouble, I get them in soon to get that going, to be proactive, and of course swelling. Here's an example: a 68-year-old female who injured herself in Florida, and she has this fracture. And she's told me the story many times. The golf cart versus car. She got hit. She was driving a golf cart, and a car hit her, and she had severe pain, limited finger motion early, swelling of the fingers, catastrophizing the event, catastrophizing her pain, and no numbness or tingling in this case. I did treat her, and then after the surgery, again the catastrophization of the pain. Again, no numbness or tingling. If she had carpal tunnel, I would have treated it concomitantly at the time of the surgery, but she did not. And throughout her time with me, we've We've wrestled with her tightness, wrestled with her pain, wrestled with her swelling, gone through a myriad of pain management options. But she never really had allodynia. She never had the swelling that was classic shiny skin, and all that comes along with the textbook case. I think the interventions are getting them into therapy early, and I'll ask Scott later about his thoughts about this as well. Edema control measures, vitamin C, pain management. Gabapentin is a staple in my practice. I use amitriptyline routinely. Antidepressants. I don't tend to use stellate ganglion blocks as much in these cases, more for the ones with frank allodynia and sweating and shiny skin. But I do think positive energy and encouragement are helpful in these patients, helping getting them over the hump. Even in 1 year post-op, she was improved, but still limited, still painful. Nicely healed, and I just saw her back. She's now 2 years post-op, and she's still in pain. She's better, but it's a long process with these patients, you know. So who's at risk? Well, female gender has been shown to be a higher risk, 5 times more likely than men. Older age, there's conflicting data. Operative treatment, 3 times more risk than non-operative treatment. Associated ulnar fracture has been interestingly identified as a risk factor. Patients with a psychiatric diagnosis, patients with fibromyalgia, and of course, patients with associated motor nerve injury have been linked to this. Now, when we look and drill down more towards the fibromyalgia, you can appreciate that even at 3, 6, 9, and 12 months, there's this study suggested that there's a notably significant higher incidence of ongoing CRPS in these patients. And they rated it as 6% of these cases had fibromyalgia. Other associated factors in this series were female gender, anxiety, and people who underwent manipulation or surgery. Is there a role for associated studies? The short answer is no. None of these studies, they've all been studied fairly thoroughly in the literature, but there's no hard science that says that bone scan or sweat test thermography or MRI or conchoidal x-rays are going to be definitive. The vitamin C topic I touched upon briefly is Ulnar had some level 1 data in 2 separate studies with top of the line journals showing that it was valuable, and they drilled it down to 500 milligrams daily for up to 50 days. Other studies more recently have casted a shadow of doubt on it. Evan New and colleagues did also a prospective randomized study and showed no benefit with vitamin C. The bottom line is I don't think there's much of a downside. Proposed treatments, and we'll go over this as first 3 treatments are therapy, motion of the fingers, edema control, desensitization. As you might imagine, when they're in a lot of pain, therapy is going to be hard, and it involves a lot of time, a lot of encouragement, and a lot of measures to try to help override the pain while they're trying to get their therapy going. And much like someone with a frozen shoulder who can't move, we often will inject them to see if that helps. And there are some data now that suggests that steroids might be helpful, like oral prednisone in these cases to help. Oral analgesics and neuropathic meds like gabapentin are helpful. Behavioral therapies, stellate ganglion blocks, I don't use as much for these unless they're classic cases. And I don't typically refer for spinal cord stimulation very often, but there are some other treatments that are out there that I'll touch upon that beyond the prednisone that might be, they seem to show some promise. When we look at studies of outcomes, not much of this is directly related to patients with associated distal radius fractures. This is a study out of Mayo from Paula Sandroni, who's one of our neurologists, looking at the Olmsted County database, and their prognosis was that not too bad. 11% of them ultimately, when the dust settled, were unable to work. But another study by DeMoss and colleagues looked at, had a much more damning prognosis. In their study, they had greater than 50% of the patients at 6 years post-CRPS still with symptoms, 16% still progressing symptoms. 31% were unable to work, 28 were working without with restrictions, and another 24% were, I think, working without restrictions. Styloid ganglion blocks also have some encouraging data, but also maybe some less encouraging data as well. As I touched upon, steroids, prednisone tapers seem to show some promise. One prospective randomized study demonstrated improved results in the steroid group when compared to piroxicam. I do think scrambler therapy is something that was introduced for chronic pain and that I learned from our cancer docs. And it's something that I think can be helpful in these patients and help them to get a handle on the pain. Now, I do also think that there's more data that needs to be had on it, and unfortunately, insurance doesn't cover some of these treatments. So I think it's important to keep that in mind. In summary, I think, obviously CRPS can be a challenging problem. Its diagnosis can be elusive. I do think having a low threshold for concern and intervention is important, and it's largely a clinical diagnosis. I think as I think about concerning findings, disproportionate pain, the obvious features, but there's some less obvious, stiffness, finger swelling, catastrophizing. If they have a history of fibromyalgia, anxiety, that sort of gets us more inclined to lean that way and have a heightened awareness of how to prevent that even. Intervention is largely therapy modalities as a big staple, and that's something that is sort of the workhorse. But medications to supplement that, help them cope with therapy, help them get over the hump, and also in more severe cases, more aggressive interventions such as styloid ganglion blocks and spinal stimulation. Thank you.
Dr. Rizzo, that was fantastic.
Oh, thanks, Kim. I went a little late.
It's a very difficult topic, but we all face it, right? And so, Scott, from your perspective, from the therapy perspective, I mean, it's this may be just my opinion, but I feel like there are times when our therapy colleagues actually see it before we do, right? And so, and I think nobody really wants to see it. I mean, and there may be that kind of trying to talk yourself out of it. No, this is just a little swelling, it's a little longer than usual. No, this is just a little, this and that. You kind of try to talk yourself out of it. But I mean, I think that, sometimes the cold, hard truth comes from our therapy colleagues. Do you have any comments, Scott, on that?
Yeah, when we were chatting earlier, we're kind of at times, you said we're kind of front line, hey, this person really has, pain that's out of a normal threshold. They really have early stiffness in the fingers. They, have that shiny skin or that redness and very, they pull their hand away when you're trying to go over range of motion with them. And I think ultimately it just, as therapists, we have to get a little bit more creative. And fortunately, there's some things that we have in our toolbox. A strategy that I've used is, a TENS unit or, even mirror therapy, just getting creative, especially if we see it following a distal radius fracture. I mean, we're still tasked with rehabbing the distal radius fracture. We just have to get a little bit more creative because you have this extra challenge, which is this CRPS presentation. But the mirror therapy, I think, is really interesting. The gradual weight bearing and scrubbing, getting some proprioception through the joint. So I think just getting a little bit more creative with what we're doing and a little bit more. Obviously we're seeing these patients a lot because they have, we don't want their issues to turn into chronic issues. So we're really trying to hedge things off at the pass.
Right. Marco, I have a question for you,
Yeah.
or for any of the other faculty, but there are times when patients present to you that have had a history of CRPS that actually have something wrong. They actually need further surgery.
Mm-hmm.
Right. And nobody really wants to tackle that. And that's always a difficult decision because
you're right. You're right. It's almost like a stigma once you get it.
Yeah.
Even if you've had it in other places, there's this like, okay.
Right.
And I
I mean,
think,
that's the audience should know that if you've had it in your knee and you're
yeah,
facing wrist surgery, that's still a risk, right? I
absolutely.
mean, so do you have any, I guess, do you have a protocol, Marco, or do you have anything that you recommend, or you know, Jay, or Amit, anybody have, like, for preparing these patients for additional surgery after they have this history?
I do. One of my colleagues in PM&R, Keith Bankston, is just one of those people that's hugely invaluable. And I do two things. You know, we have these catheters now that we can put in for surgery, like a 3-day catheter. We call them on-cue pumps here. I don't know if you have them out there, but I think that's something that they're going to get. Like that's in the cards for them. And not only that, probably an extra day. Like I admit them overnight, and then we hook up the on-cue pump the next day, so they get like 4 days worth of like anesthesia. You know, but I also curbside Keith to say, hey, Keith, based on their history, based on the type of CRPS they had, based on how they did, do you have recommendations about what should I pharmacologically? And oftentimes we'll prophylactically give them, you know, start them on gabapentin, you know. So we sort of, well, I'll do those two things. I'll lean on Keith, and I'll be prepared for a catheter for them perioperatively.
Jay, do you have any comments?
I have not used the Q pumps, which I think is a great idea. But a question that I had was how you incorporate maybe the pain management service. Like that's something that I lean on because I'm not great at pain management. And if they need higher doses of, you know, medicines that I don't feel comfortable prescribing, I think it's great to have another team helping. And then it's kind of like a three-legged chair. We have therapy involved, we have the surgeon helping. And I like the fact that you put being in a positive and encouraging part of the process. I think that's a lot of the patients who came to me with CRPS. People told them that they were a baby, or that they, you know, why are you complaining so much? They're completely misdiagnosed. And so being a more positive person, listening, helping them, but how do you incorporate pain management as far as that, Marco?
Yeah, Jay, that's a great question. You know, it's our pain service that sets up the on-cue pumps, so they're integral from the beginning. You know, they're part of the anesthesia team. So and they're in-house all the time, and they often will you know, as part of the consult, they'll give us recommendations for post-operative pain management.
Yeah.
So that sort of comes with the service. It comes along with the on-cue pump. But that's a great point, Jay.
I also use them for help in deciding who should have a styloid ganglion block, because our pain management service are the people who do that procedure. And so I just tell the patients, I don't know if you're a good candidate for it. I tend to focus on if you have sympathetic mediated CRPS, those tend to be those people who would respond to it. But I just say, you know, the pain management people will really have a better idea if you're a good candidate for it. But my understanding, and correct me if I'm wrong, Marco, but if a person is a good indication for the styloid ganglion block, the earlier time period that they receive it, it's a little bit more effective. Is that borne out in the later literature?
Exactly. That first study that I showed, actually, they had very good results. But they did stress earlier intervention if it's and I share your concerns, Jay. I don't consider myself an expert in terms of knowing who's a good candidate for the styloid ganglion block, and the preoperative consultation helps me. It helps me in case, because I think what we're doing is hoping for the best, preparing for the worst. So it's almost like, okay, let's play out a scenario where they just get a full-blown CRPS catastrophe. Right. How are we going to mitigate that, or what's our plan for that? Because more often than not, even with a history of CRPS, we go through all these hoops and they end up doing okay. Sure. They don't get another flare, most of them. Right. But because they've had it before, and because it seems that a lot of how God made you predisposes you to developing CRPS, it's a justified stigma. I mean, the whole concept of you get it once, you're sort of labeled, and I think that's a justifiable label.
Very true. Well, we're fast approaching the end of our session, but I want to thank everybody.
Sorry, I just want to make
Oh,
one
sure.
point, and that is, Dr. Kleiner taught me that you should not put your head in the sand. The moment you do suspect that you're getting a CRPS, jump on it and throw the whole kitchen sink at the problem. Otherwise, the patient will get worse. So if you attack it early and nip it in the bud and do all the protocols that Scott was talking about, scrubbing therapy, TENS unit, mirror therapy, everything. And then that way you can, cut the course short.
Yeah, I think yeah, I would echo that as well. I think that's fantastic. Well, thank you, everybody. Dr. Mudgall, do you have any comments or?
Okay.
So, well, anyway, we're very happy that all of you participated. I thank you for your time. And they're posted here some of our upcoming sessions. And please join us next week with Dr. Bridgman, who will be the moderator. And then continue looking for our upcoming courses in Tampa and some of our webinars. I think that will be very educational and very helpful in your practice. So anyway, thank you again, and good night to everyone.